Our next section is anemia. Anemia in pregnancy, very common. This is our case. An 18-year-old, gravida 3, para 2, had prenatal labs drawn at 18 weeks. The CBC showed hemoglobin 9.5. Less than 10 to 10.5 is anemia. Her hematocrit was 28. Her MCV is 75. Mean corpuscular volume. What's the lower limits of normal? 80. So she has microcytic cells. Her RDW, red cell distribution width, is elevated. If you have a woman who is pregnant, she's anemic, microcytic, the most common cause is iron deficiency. And that would certainly make sense. Her first child was delivered 2 years ago, her second child 1 year ago. What do you think her bone marrow iron stores are? Zip. She's completely exhausted her bone marrow stores. And so when you're treating her, you not only want to return her hemoglobin to the normal range, but you want to also restock her bone marrow iron stores. So she'll need to be on iron for at least 6 months. Let's look at anemia in pregnancy. The different kinds we're going to look at briefly are iron deficiency, the most common. This is going to be microcytic. Folate deficiency. This is going to be macrocytic. Sickle cell, and thalassemia. Hemoglobin less than 10, some would say 10.5, is clearly anemia. And we want to look at, is this heme anemia or globin anemia? The heme anemia is nutritional anemias, and that is iron deficiency and folate deficiency. If the MCV is less than 80, RDW is elevated, that's consistent with iron deficiency. Management is ferrous sulfate, 325 milligrams, 3 times a day. Giving more is not going to help. It'll just cause GI distress. There's only so much that can be absorbed across the jejunal mucosa. If the MCV is elevated, RDW is elevated, the most likely diagnosis is folate deficiency. Management of uncomplicated folate deficiency is 1 milligram of folate a day. This is a water-soluble vitamin. You cannot give excessive amounts. The globin anemias are the inherited anemias, and that includes sickle cell and thalassemia. Sickle cell is a production of abnormal hemoglobin. Thalassemia is a decreased production of normal hemoglobin. The diagnosis of these is made by electrophoresis. The big concern with sickle cell anemia is sickling, which is stimulated by hypoxia. So avoid hypoxia. Now, you don't need to give extra iron because these women can recycle their iron, but if they are hemolyzing rapidly, they may need to be on high doses of folate. Thalassemia is basically conservatively managed. There is no treatment. In pregnancy, we have an increase in plasma volume. We talked about that. But we have a decrease in the hemoglobin. And this is because of the hemodilution. We have a greater increase in plasma volume than we have in red blood cell mass. And you can see here, normal hemoglobin in pregnancy can go as low as 10.5 up to 12.5. Iron deficiency is the most common, 8 times more common. It is the hemoglobin molecule which is affected because of decreased heme production. MCV is decreased, RDW is increased, and remember, the bone marrow iron stores are completely gone. If the mother is iron deficient, is the fetus iron deficient? No, because there is active transport of iron across the placenta. Management of iron deficiency is ferrous sulfate, 325 milligrams 3 times a day. Prevention, every prenatal vitamin should have at least 30 milligrams of elemental iron a day. And 1 tablet of ferrous sulfate, 325 milligrams, has 60 milligrams of elemental iron. Folate deficiency. This is a heme problem, is a nutritional anemia, decreased heme production. MCV is going to be increased, RDW is increased. What will the peripheral smear show? Hypersegmented neutrophils. Effect on the fetus, low birth weight, and we talked about this before, neural tube defect from decreased folate. Here you can see is this multi-segmented neutrophil, right here, along with these macrocytic cells. Treatment for folate deficiency is folate 1 milligram a day. Prevention, all women in reproductive years should have 400 milligrams or micrograms or 0.4 milligrams. And if she's high risk, 4 milligrams of folate a day. That's type 1, type 2 diabetes, previous baby with neural tube defects, positive family history for neural tube defects, and women who have seizure disorders. Sickle cell anemia. And here we can see the sickle cells. This is stimulated by hypoxia. This is the effect not on the heme, but on the globin molecule. And we have abnormal globin chains which are produced. This is autosomal recessive. And if she has only one gene, we call that sickle cell trait. What is the impact of sickle cell trait in pregnancy? The only abnormality is increased urinary tract infections. But if she has sickle cell disease, which means she is homozygous in pregnancy, lots of potential problems: spontaneous abortions, intrauterine growth restriction, fetal death, preterm labor, and these pregnancies don't do as well. If you have a low MCV, you should always think of iron deficiency. If you have a high MCV, you should think of folate deficiency. Now, how about B12 deficiency? I have never seen a B12 deficient patient who is pregnant. She becomes infertile. So if you have a macrocytic anemia in pregnancy, it is always going to be folate deficiency. Hemoglobin less than 10, MCV low, RDW up, that is iron deficiency. Hemoglobin less than 10, MCV over 100, RDW elevated, that is going to be folate deficiency. Hemoglobin less than 10, black ethnicity, hemoglobin S over 40, that is consistent with sickle cell anemia. Okay, let's look at some high-yield review questions in terms of anemia in pregnancy. And this would be a great board exam question. What is the most likely diagnosis of anemia in pregnancy with the following risk factors? Multiple gestation. Multiple gestation, we have increase of nutritional demands on the mother's body stores, and so we have increase in iron and folate deficiency. Seizure disorders, we have decreased absorption of folate, so folate deficiency is more common. How about African descent? What do you think of? We think of a sickle cell disease. And Southeast Asian descent, we think more of a thalassemia. So those would be good board questions. Now, I don't have a knee-jerk response to this question. A 25-year-old black multigravida is found to have anemia. What's the most likely diagnosis? Now, yes, we think of sickle cell with black women, but is that the most common? Not at all. The most common anemia in all women is iron deficiency, not thalassemia, folate, or sickle cell. So iron deficiency is still more common. And that is the end of anemia in pregnancy.